Let me welcome you to this workshop. We'll show you how an early diagnosis of Alzheimer's disease can be performed by using disease markers extracted by diagnostic algorithms run on diagnostic images such as MRI and FDG PET. And our project is developing a virtual environment. Our project, so I need to, yeah. Our project DECIDE, which is co-funded by European Commission in the framework of FP7, is developing a virtual environment where this, sorry. A virtual environment, as I was saying, that clinicians and imaging experts can use to transparently exploit these disease markers. Such markers are not visible to the naked eye, so you can't just look at the diagnostic images and see them, but they are there and they allow us to perform a very early diagnosis before at the preclinical phase. So, in our opinion, this is very important for the future of diagnosis and prognosis of this disease. So my colleagues will discuss imaging markers on MRI. And for this, we have the speech of Professor Giovanni Frisoni from IRCCS Fate Bene Fratelli of Brescia, which is our scientific coordinator. And then we'll have a presentation about markers extracted from FDG PET by our colleague Chiara Ceramio on behalf of Professor Daniela Perani. So before giving the floor to our speakers, I would like to announce that our service is to be released in a couple of months, and at this stage we are starting the validation phase of the service. So I invite you, if you are interested, to become part of our user panel. We have already quite a few expressions of interest, but we would like to enlarge our panel of early adopters as much as possible in order to start early to accommodate your suggestion and your feedback to make the service more usable and more suitable to the real life, daily life in clinical practice. So now I'm giving the floor to Professor Giovanni Frisoni, who unfortunately couldn't be here in person, but he managed to be here virtually. And his collaborator, Alberto Ridolfi, is here in a video conference to answer any question that the presentation may raise. So, just a second.
Good afternoon, everybody. It's a pleasure for me to be with you, or rather to talk to you today, although remotely, about the DECIDE infrastructure and about how the DECIDE infrastructure falls into a larger framework, a larger context of what we've learned and how we will treat patients with Alzheimer's disease in the coming years. First of all, let me frame today's discussion into a historical context. A recent paper by Dennis Selko published in Nature Medicine has outlined the main discoveries in the field of Alzheimer's disease since in the 60s. And after all, the first electron microscopy description of paired helical filament and amyloid plaques dates back to the early 60s, which means about 50 years ago. And the cholinergic deficiency has been described in the early 70s. Discoveries of that A beta is in plaques and cerebral amyloid angiopathy and tau is in tangles is in the 80s. So it's not that long that we know the critical, what we now believe are the critical factors, that the critical molecular factors that bring about the development of neurodegeneration of Alzheimer's disease. It's only in barely 25 or something years. And only early in the 90s, the first publication on amyloid, on the amyloid cascade hypothesis have appeared, as well as in the mid-90s, the discovery that ApoE4 is a risk factor that decrease A beta 42, increase the levels of tau in the CSF of AD patients are associated with the disease, and the first APP transgenic mouse with AD-like pathology. So it's only barely 20-something years that we have animal models, albeit imperfect, for Alzheimer's. And in the late 90s, the discoveries of the mutation in tau as a cause of FTD has been published, as well as the discovery that presenilin is the catalytic component of gamma secretase, which has allowed the development of recent drugs. It's true that a few years ago, in the late 2010 years, a few drugs have failed in Alzheimer's disease: tromiprazole, flurbiprofen, and most recently semagassostat, the gamma secretase inhibitor. But after all, these failures should be viewed in a relatively recent context of discoveries. These drugs have been developed based, and the drugs that are currently under development have been developed based on the knowledge, of increased knowledge on the pathophysiology of the disease. And now I would like to share with you what we believe now is the pathophysiology of Alzheimer's disease. The two main phenomena are plaques and tangles. Tangles have been described, both have been described by Alzheimer's, but as I said, only recently we know what plaques and tangles are made of. And Aiko Brack and his wife have described the progression, the topographic progression of tangles in the brain, starting in the transentorhinal cortex and then moving on to affect the temporal and orbitomesial cortex and the posterior, the retrosplenial cortex, and finally affecting the whole neocortical area with relative sparing of only the sensory motor and visual cortex. This has been known for a relatively long time, for 15, 20 years now. And what's interesting and what's remarkable is that the progression over time of the other major molecular phenomenon featured by Alzheimer's, amyloid plaque, is completely different. The progression, the way plaques expand, affect the brain over time is completely different from that of tangles. And this has been described more recently, barely 10 years ago, by Dietmar Tau. And as you can see here, the first site of deposition of plaques is in the neocortex. And only afterwards the cingulate cortex is affected, and later on the diencephalic nuclei, and then the brainstem nuclei, and finally the cerebellum. So as you can see, the progression of how tangles and amyloid affect the brain are completely different. What we know is that they are in some way connected to each other. We don't know what connects the two phenomena, but definitely the two phenomena are related. What we know, what we also know now, is that symptoms follow tangle deposition, and tangle deposition is what gives rise to neurodegeneration. Amyloid per se is unable to give symptoms, is not associated with symptoms. Tangles is associated with neurodegeneration, meaning neuronal loss and synaptic loss, and to symptoms. So the cascade is amyloid deposition, tangle deposition, neurodegeneration, and development of symptoms. We have a number of markers now. We have, in the past few years, we have developed a number of ways to appreciate the development of amyloidosis and neurodegeneration in the brain of patients. And this is amyloidosis can be appreciated with amyloid imaging and by measuring a beta 42 in the CSF. Neurodegeneration can be appreciated with volumetric MRI, with functional MRI, with FDG PET, and with by measuring tau in the CSF. And here I should also mention neurophysiological tools such as EEG. Another recent acquisition, is that these markers of amyloidosis and neurodegeneration change over time at a different rate, at a different speed. Some take off earlier in the disease process, others take off later. This is a slide where you can see the whole development of Alzheimer's over a time span of about 30 years, and here you can see that amyloid markers take off very early in the disease stage. They become abnormal when the patient is still asymptomatic or only mildly symptomatic, and then the accumulation flattens out. functional and metabolic markers, functional such as fMRI or EEG changes, or FDG PET, the assessment of brain metabolism or cortical metabolism, take off slightly later, but continue to deteriorate progressively until a relatively more advanced stages. The last phenomenon is represented by structural changes, atrophy, which takes off even later in the disease course and flattens out much later. And actually we do not know precisely when. Based on these relatively recent acquisitions, a task force, actually 3 task forces, have developed a new diagnostic criteria. In April this year, the so-called revised NIA AA criteria from the National Institute on Aging and the Alzheimer Association have been published. And these criteria are supposed to allow the detection of Alzheimer's not only at the dementia stage, which we used to do, which is what we've been doing for the past almost 30 years now, but also at the earliest stage of my cognitive impairment, and perhaps even at the totally asymptomatic stage. How this diagnosis is made? Well, with the use of biomarkers, with the use of amyloid markers and neurodegeneration markers. This slide once again summarizes the markers of brain amyloidosis and neurodegeneration that we believe critical to for an earlier diagnosis and a more accurate differential diagnosis. Amyloid PET and CSF A beta 42 for amyloidosis, and for neurodegeneration, structural changes such as hippocampal atrophy, FDG PET changes with a specific pattern, tau in the CSF, and changes on neurophysiology. Of these markers, you will appreciate that neurophysiology is in gray rather than in blue, because it's regarded as a less mature biomarker, while the others are quite recognized as markers, as disease markers. In the context of the DECIDE infrastructure, we have implemented tools to measure, to help clinicians measure mainly FDG PET, which is what you will see today from my colleagues. But we also have installed applications to measure EEG changes, which you will also see from my colleagues today. We are in the process of implementing tools to measure hippocampal atrophy. So, as you have appreciated, the science of Alzheimer's disease has changed dramatically in the past few years, and the concept of Alzheimer's has also been changing, and the practice of taking care of patients will change very soon. The publication of the new criteria indicates that clinicians should be aware that they will soon be required to use markers, and they should be ready to do that. What this slide shows you is the development is one of the steps in the development of standard operational procedures for hippocampal volumetry. This is something that is mandatory. The development of SOPs is mandatory to use biomarkers in clinical practice. This is what we want to help with DECIDE. DECIDE wants to help in the process of developing standard operational procedures for biomarkers to be used in the clinical practice. And with this, I simply thank you for your attention and leave my colleagues the task of explaining you what how DECIDES works and how it can be used to help in the clinical routine. Thank you for your attention.
So, indeed, my colleague Fulvio Galeazzi, who's our project coordinator, later will show you how, in very simple words, how the service works. But now I would like to give the floor to our colleague, Dr. Chiara Cerami.
So, good evening to everybody. I am here in place of Professor Daniela Perani, so talking to you about the use of FDG PET imaging in the routine, so in clinical practice. And in particular, I would like to talk to you about the subjective analysis, so the visual inspection of... May I? Okay. Perfect. So, on the clinical analysis of FDG PET from subjective to objective tools. First of all, as all of you know, dementia is a high prevalence disorder, so it is expected to have quite 10 million people affected in the West Europe. The prevalence is quite lower in the Eastern Europe, but as you know, it's a high prevalence disorder, so it is important not only in the neurological field, but also in clinical, in medicine at all. And many of these cases, however, are above this dementia threshold. So when clinical and neuropsychological tools are often not so sensitive. So what we know is that sometimes we, in the last 20 years, so we, as a researcher, we provide new biomarkers of brain amyloidosis and neuronal injury, so from synaptic dysfunction and neurodegeneration. So when we provide PET imaging with the PEEP compound for the increased uptake of amyloid and also the decrease in CSF of beta amyloid, which are biomarkers of brain amyloidosis. And we also provide a new biomarkers of neuron injury, which is the FDG PET imaging, and in particular the hypometabolism of temporoparietal regions in Alzheimer's disease. So it is very important to use in clinical practice these new elements, these new tools, so imaging, CSF, because they became in the research diagnostic criteria for Alzheimer's disease supportive features, as you can see. So the supportive features are pathophysiological markers and topographical markers. So, and in this way, you can see that FDG PET imaging is a very high level topographical biomarkers. Which is the role of PET imaging in the diagnostic practice of each neurologist? The role is that we can provide specific metabolic pattern for the different neurodegenerative disorders. So, but what we have to notice is that the simple visual inspection of this, as you can see on the left side, of this radioactivity tracer distribution is not so sensitive as is the quantitative analysis, as in this case with the statistical parametrical mapping. So many studies performed with voxel-based analysis have described typical pattern of metabolic changes in neurodegenerative disorder. This study, for example, performed on 96 patients in many different neurodegenerative disorders, so provide specific patterns. For example, for Alzheimer's disease, you can see the temporoparietal involvement, hypometabolism, so, and also in this case, you can see here the posterior cingulate cortex hypometabolism, which is a high sensitive element, sensitive sign of Alzheimer's disease. And in this case, it's very important to see that a voxel-based analysis could provide could also differentiate Alzheimer's disease from the other dementia. For example, you can see that in dementia with Lewy body is a more posterior involvement of the occipital regions, and also in frontotemporal dementia. And the last one, there is a more anterior involvement of ventromedial cortex. So many other studies can perform with the group comparison. So, as in this case, with the atypical Parkinsonism, so corticobasal degeneration and progressive supranuclear palsy, described specific quantitative pattern. For example, in PSP, you can see the midbrain involvement and the involvement of the midbrain involvement of the prefrontal cortex, and in particular, you can see that is totally different from corticobasal degeneration, which is more lateralized and involves frontal and parietal cortex. So even in a certain way, this is the case that is quite difficult in clinical practice. So, and as this study show that also in frontotemporal dementia there are elements that with a quantitative analysis could differentiate frontotemporal dementia from other neurodegenerative disorder. And in particular, this study showed that performed in 3 different centers, so with different patients, different controls, and different PET scanners. You see that all these 3 groups provide the same results, so the same involvement of ventromedial prefrontal cortex. It is very important because we provided, in a certain way, a tool which is able to give us a sign which is high sensitive. But all these studies provide results from a quantitative analysis on FDG PET imaging. So also in the primary progressive aphasia, it's possible to differentiate the different variants. So leukopenic variant, semantic variant, and non-fluent variant, which is, however, quite heterogeneous. And as you can see, in new criteria for primary progressive aphasia, you can see that there is a level of diagnosis which is imaging supported variant, and in this imaging supporting variant is there the involvement. Is there important to know which what imaging shows? So it's important to determine the presence, for example, of left posterior frontoinsular atrophy on MRI, or, for example, the hypometabolism on PET imaging. So, on this study, for example, it's very important because it's quite, it shows metabolic changes in vivo in Alzheimer's disease. And if you see the pattern, the red pattern, of reduced, also the hypometabolic pattern is quite similar to what Professor Frisoni showed you from Brack and Brack neuropathological changes. So it spared the portion which is in the middle, so, and involves temporoparietal regions, so also the posterior cingulate cortex, and also in the later stages of the disorder, the prefrontal cortex. What we can say is also that MCI, which is a highly heterogeneous disorder in clinical practice, it could be differentiated with the use of these specific imaging tools. So, as this study shows, the MCI which convert present since the beginning, the typical hypometabolism on parietal cortex and also on the posterior cingulate cortex, which is highly sensitive and highly prone the clinician to consider that this patient will progress to Alzheimer's disease. So you cannot see these elements on the MCI, which do not convert at a 12 months follow-up, but you see just a specific pattern. So it is possible to use this sign as important element to determine, to classify the MCI patient as a pre-dementia stage of Alzheimer's disease. From new Dubois criteria, you can see that the evidence and biomarker of imaging is highly supportive for the presence of Alzheimer's disease pathological changes. You can call this patient prodromal AD, and which is what is important for us. The importance is in clinical practice that we can use it since the beginning, these tools to determine if a patient is able to go to a clinical trial, for example. So it is very important in a clinical way. We can see that also everything that we said, it is possible to transfer in a single subject, at a single subject level. So, for example, I present you some patients. For example, this case is a probable Alzheimer's disease patient, in which you can see at the visual inspection is evidence of metabolism on the parietal cortex bilaterally, but it's this element at visual inspection, it is quite biased by demographic or by atrophy, so it is not a real sign of functional changes. The functional changes, it results from the SPM analysis. So, and this, as you can see, the typical pattern of an Alzheimer's disease above. So, this is another very interesting case because we saw this patient for a memory impairment disorder, so and apathy and anomia, starting 1 year before. At the first time, we thought that this patient was, because she was functionally impaired, could be a frontal variant of Alzheimer's disease. When we do FDG PET imaging, we saw instead that this patient present not only a huge prefrontal cortex hypometabolism, as you can see also on above with the visual inspection, so involving the orbitobasal and the ventromedial cortex, but also another thing, so you can see also the basal ganglia involvement, which is a typical sign that is not present in an Alzheimer's disease. So, this study performed with neuropathological confirmation show us that it is possible to differentiate Alzheimer and frontotemporal dementia in vivo, but as you can see, the scenario it means the clinical neuropsychological evaluation. So they often lack of enough confidence in the diagnosis. And what SSP means, it is the quantitative analysis of PET imaging. It is, on the contrary, really quite always, in all these cases, correct. So it is able to say to us which is the right pathological disorder, also in vivo. And in this case, you can see that PET imaging, just with a transaxial visual inspection, it is not able, as the quantitative analysis, to say to us clinicians if a patient is an Alzheimer or frontotemporal dementia. So the specificity and the sensitivity of the quantitative analysis is much, much more higher. But when it's very important to use the PET imaging, the new biomarkers imaging, is when the clinicians are not able to say if a patient is really at the neurodegenerative patient. So in very early phases of the disorder, as this case show a selective long-term memory impairment and a history of 2 years of this disease duration, it is quite, with a normal brain MRI, it is quite difficult to say if this patient hide a neurodegenerative disorder. As you can see, the visual inspection of PET imaging does not give us any information. But in this case, SPM analysis revealed a subtle hypometabolism on the left hippocampus. And as you can see, I overlaid the two images. It is quite impossible with visual inspection to see that. So we follow this patient with the neuropsychological evaluation every 6 months. And after a year, this patient converted to an Alzheimer's disease. So this is another case in which we have a quite normal visual inspection, quite normal PET with visual inspection, but the SPM analysis showed another pattern which is highly suggestive of a degenerative disorder. Sometimes, instead, it is very easy to do also for the nuclear medicine centers, for all nuclear medicine centers, it's very easy, the diagnosis. In this case, this Alzheimer's disease, of course, with here a history of a year and a mild mini-mental state examination, mild impairment. So, oops. Oops. So, okay. In that case, it was quite evident that the patient was impaired and that has a neurodegenerative disorder. So, but this is the case that we can call a pre-dementia stage of Alzheimer's disease, so a prodromal Alzheimer's disease, because the PET imaging is certainly. Forse il prossimo. No, prossimo. La prossima. Okay, so in this case, PET imaging is positive for involvement of the temporal and parietal cortex on the left side. So sometimes it is useful to do also PET imaging with quantitative analysis because it's difficult in clinical at a clinical level to say if a patient has a neurodegenerative disorder. In this case, we with a clinical history of 4 years of disease duration, it is quite difficult that a mild long-term memory impairment and neuropsychological evaluation means a degenerative disorder. But we do not stop at this level, and we want to perform PET imaging. And the PET imaging confirmed the clinical suspicions because there was nothing, there was no hypermetabolism on the SPM analysis. So what we can say is that an international consortium of investigators argue that due to the high sensitivity of FDG PET imaging, a negative, so a normal PET imaging in MCI strongly suggests a normal outcome at follow-up. So this is described the very important significance of the PET imaging in MCI. Okay. So another thing to say is that the involvement of the posterior cingulate cortex, so as you can see here, and so the retrosplenial cortex, as you can see also over there, it is a very important element because it's an early functional marker common in MCI and in Alzheimer's disease. So the posterior cingulate cortex hypometabolism highly suggests that an MCI will progress to an Alzheimer's disease. This is what this study, these case reports revealed, that these two cases with described as MCI, amnestic MCI, at the beginning, they developed Alzheimer's disease, so confirming the importance to use the new criteria of pre-dementia stages when there is a PET imaging suggestive of Alzheimer's disease changes. All what we can say is that what we've done is something about an excellent center of nuclear medicine. So we perform single subject level quantitative analysis in each subject we do. We see in clinical practice in Sara Ferri Institute. But the aim of Dayside is that this possibility will be given to everybody, to all clinicians, that could be put in together in a big net connection with this excellent nuclear medicine centers or imaging centers. So what we have done also in the Dayside project, we as Nuclear Medicine Center, we increased the number of control subjects, so to perform single subject analysis not with versus a low number of controls, but with a very high numbers of controls to increase the specificity and sensitivity of our analysis. So, and we create also a specific FDG template because the SPM template is was not created for FDG analysis, and so with a total of 140 controls. So I leave this with a total of 140 controls, performing some specific analysis. So these are different steps. We reach a final set of 113 images and reaching more statistical power. What I mean is that we perform a statistical analysis as you saw before, no? The case I report before, 1 versus 19 subjects, and we perform also the same analysis with this big database after this big database creation. So one single subject, in this case an Alzheimer's subject, versus 113 subjects. And what is the result? The result is that there is the same pattern, the same hypometabolism pattern, so, but there is a larger cluster, so in extension, and also a higher significance and a higher statistic significance. So it is, of course, a success for us. Because it means that it could be very useful to specifically in very early phases. So the second point is that we create this FDG PET template, including not only controls but also patients for the normalization. And the patient will be, they were representative of the incidence of each form of dementia, so as you can see, and they were matched controls and patients for the demographic variables. And what we create is a dayside template for this SPM analysis, which has a totally different contrast. As you can see, the intensity is totally different from the SPM PET template and this PET template. So it means that it is able to recognize also subtle metabolic changes. This is another images that shows the difference between the SPM template and the dayside template. So you can see how the sulci, how the cortex is more defined in our template. So the final outcome, of course, is to reach more sensitivity. As this study said, that higher sensitivity basically could be reached, increasing the control groups. So at the end point, I would like to leave you this message that currently we are here. So we are able to recognize Alzheimer when it is mild in a clinical way. The future is that we could include not only the very early stages of Alzheimer, but probably the stages before. So when normal aging are becoming mild impaired. So, and that's all. Thank you for your attention.
Thank you very much, Chiara. And yes, if you have questions, please shoot. No question? So, yes, I remind you that there is another virtual presence here in case you want to make any questions about the hippocampus segmentation. So, if not, I will give the floor to my colleague Fulvio Galeazzi, who will explain how the service works. Okay, what we did is to explain you what's behind the service, but now our purpose is to show that all this complexity is masked behind a very simple and easy-to-use service that we believe we can really bring to clinicians. That's our main objective.
Good evening, everybody. Thank you for joining us. I'm the project manager of the DECIDE project, and I only have a few slides, don't worry, very short, to show you what we are trying to set up. You see on top of the slide the project participants. There's some technical partners, some partners which deal with the research, like universities, some hospitals. This Hospital of Toulouse, which is a center which is our connection to the network of excellence of hospitals and research institutes, and Alzheimer Europe. Okay, so what we aim to do is, our aim is to create an infrastructure and a service which is dedicated both to research and to the clinical practice, to help people working in the field with the early diagnosis of Alzheimer's disease and other neurodegenerative diseases. So you all know that Alzheimer is one of Europe's greatest challenges for the next few years. And the important thing which is new in this project is that this is not only related to research, but also, as you heard, to give clinicians a quantitative measure to be used in the clinical practice. The project started the 1st September last year. It is just 1 year old, and it will last for a little less than 1 more year. So it's coordinated by technical partner, the Italian Research and Education Network, which is also connecting hospitals in Italy. And technical coordination is Cometa, which has a great experience with this distributed computing. Our scientific coordination is Dr. Giovanni Frisoni, who was also the principal investigator of another project, NeoGrid, which had more or less the same idea of providing easy-to-use computing power and tools for the research world, but this side aims at widening this to the clinical world. Wait, that. Okay. So this is the detailed list of partners. The layer which is of more interest for you, I guess, is the last block, where research and healthcare partners are listed. As you see, there is a combination of all stakeholders being involved, from the provisioning of the network to the computing to research hospitals, Alzheimer Europe, which also includes patients, and centers of excellence. The basic idea which has guided us through the implementation of the service is that we wanted to provide a very powerful tool, but masking the complexity for the end user. So the interface for the doctor is just a web interface, which is easy to use. It can be accessed from everywhere. Essentially what will happen is that the doctor will be presented with a web page. It will be possible to upload images, DICOM images, and this will have the same level of complexity as sending an email with an attachment, nothing more than that. And then this image, with all the security which is implied by the fact that we are treating patients' data, will be transferred to the computing centers, where what we call the applications or the algorithms, so the SPM, for example, or the EEG algorithm will be run. And the outcome of this, at the end of this, the doctor will receive a report. It's a PDF file with a report, with information, with quantitative information, which will help him to assess the case. So as of now, we have 4 applications in our portfolio. One is Grid SPM, which you just heard about. And this is for diagnostic, as a diagnostic value. Another one is an application which measures this subcortical segmentation. It works on magnetic resonance images, and it measures the volume of the hippocampal. This is called AdaBoost. Then, which was mentioned also by Dr. Frisoni, we have another application which, for the moment, is aimed at research, but may be used. It looks very promising, and there should be a paper published by the end of this month. And since it's just electroencephalography, it may be well used for screening purposes. And this implements EEG processing. And then we have another application which is still to be used by researchers for the moment. And this concerns the analysis of biomarkers with a rather innovative way through the use of an artificial neural network. So my presentation is just finishing here. I hope we managed to give you an idea of what we are doing. And now we will be glad to hear from you. So we are at the phase now where the service is essentially ready for takeoff. It will be released in a couple of months. This is the link to the web page where you can find more information. And what is important now, since we want to provide a service, we would be glad to hear your feedback, so either immediate or at a later stage. So we're asking you to get involved with the project, and we propose you to become our beta testers to participate in the validation and testing phase, which is going to start very soon. So if before leaving, you may leave us your contact information or stop by Maddalena, who is sitting there in the room. So we will be grateful. Okay. Thank you very much. I think if you have questions, we have Alberto Edolfi online, who may answer. He is collaborating with the group of Giovanni Frisoni, and Chiara, of course, will be glad to answer your questions.
If you want, you can also ask questions while taking a coffee or so.
Questions are quite simple ones, they're twofold. First of all, of all the partners, I note that Imperial College is one of your partners, and I note on one of your slides, I think it was the last but one, you mentioned LONI, which am I right in assuming that's London Imperial or London, something like that? Can you tell me specifically what Imperial College's role in the project is, what sort of work they're doing in relation to the other partners?
Okay, so Imperial College is in charge of the creation of our multimodal database. So they had, in particular in the first year, an important role in defining our reference database. As you have seen in the presentations, we need a quite large database of quality data in order to perform statistical computations. So it is very important for us to create a standardized multimodal database and to ensure our users about the high quality of data, as well as, of course, security and data properties problems. Also, Imperial is in charge for the last application, the one that implements the neural network. And they have already a couple of publications about on the standalone version of the application. They are, of course, still, this is still a research application, so we are not suggesting our users to use it in a clinical environment.
Are they people in the Faculty of Computing or Faculty of Mathematics, or a combination of both?
It's the neurology department.
I see, it's part of the neurology department.
Yeah.
My second question is, it's more about the fact you're concentrating on Alzheimer's at the moment. You mention other neurodegenerative conditions. What are your plans to look at other dementias, for example? Let's take DLB for an example.
Well, in principle, we are very much interested in enlarge the portfolio of services and algorithms to be run on the infrastructure, and we would be glad to consider other algorithms. And of course, we have, as you have seen, we have a team that includes different competencies. So we would gladly consider to help you to port any algorithm in relating to other disorders into our infrastructure. Of course, whether this can be done in the present project or not, this should be evaluated on the basis of how much effort is needed to port the application. But for sure, we are very much interested in considering this, and maybe at a later stage, even considering to span over other diseases or other even organs in the future.
Thank you very much.
The idea is to have a box with a toolbox with a lot of tools for clinicians to use and for researchers as well to use.